Welcome to Bridges to Health and Healthcare. On behalf of Fort Drum Regional Health Planning Organization and North Country Initiative, thank you for watching. We are pleased to be able to offer this internationally utilized training to our partners, in part through the generous support of a grant from the New York Health Foundation. And we hope you'll find it worthwhile and useful. We offer this training virtually and on demand because we know the time constraints you face. This is often presented as a full day or multi-day training, and we have significantly condensed it. Whatever your familiarity with Bridges Out of Poverty, we hope you will find that it aligns with and complements other initiatives your practice is already doing, including patient-centered medical homes, or PCMH, and value-based contracting. So what is Bridges to Health and Healthcare? It is a set of strategies based on the book of the same name which you have received, or will receive shortly. In turn, Bridges to Health and Healthcare is based on the Bridges Out of Poverty body of work, or Bridges for short. The Bridges model has been around for about 25 years and has been utilized throughout the US and internationally. Simply put, you can think of it as a training in economic diversity. Within the context of healthcare, the objective of the training is for each of you to answer the question, how can we meet the healthcare needs of low-income, under-resourced people in our community? And what positive side effects might your practice realize by doing so? Along with the book, we also sent you a worksheet titled Utilizing the Bridges to Health and Healthcare Concepts. Please have this page available and jot down your ideas as you watch. So one thing we'll very quickly point out is that Bridges is not a program, but more a set of strategies and a lens through which to view economic classes. Different economic classes exist, and for simplicity's sake, we can think of them as broken into three main groups: poverty, middle class, and wealth. Each class brings with it an environment and a set of what's called hidden rules for how people within it think and act. No one class is necessarily better or worse than the other, just different. And observations about the classes are not meant to be definitive or absolute or stereotypical. Instead, they are meant to be helpful generalizations and patterns. Bridges rests on the notion that if we can better understand each class, it will give us a common framework and language by which we, as members of different classes, can talk about economic class. The end goal of Bridges is to have representation from every economic class at the decision-making tables in any given community, and to create an environment where everyone, regardless of their economic class, can live well. We also want to acknowledge from the start that some of you watching may have lived experience of poverty. So as we go throughout this training, does any of the material resonate with you? Which parts? One way we can think about how economic class and healthcare intersect is through the four lenses. In other words, healthcare happens on an individual level, an institutional level, the community level, and a policy level, the latter of which, through county, state, and federal policies, impacts all other lenses. So let's set the stage. We know our country is on an unsustainable path of healthcare spending. In fact, a full 20%, or 1/5, of our country's GDP is now spent on healthcare. That's 20 cents on every dollar. It's significantly higher in comparison to other quote-unquote developed or OECD countries. So with all that spend, our country must have the best healthcare system and the best healthcare outcomes in the world, right? Wrong. Our health outcomes related to both quality and quantity of life are dismal in comparison to other developed countries. What are we doing wrong? Bridges doesn't pretend to be able to solve all of these problems. There are definitely contributing factors that fall outside the scope of Bridges, such as the Byzantine spectacle that is American fee-for-service reimbursement, for instance, but As research develops over the decades, we can say with a high level of confidence that health, education, and socioeconomic status are intimately linked. And with a significant portion of Americans experiencing socioeconomic stress, we have to examine economic class and its relationship with health and wellness. One such study actually equated the presence of poverty to a loss of 13 IQ points. The experience of poverty is exhausting. Living on suboptimal resources for an extended period of time, a constant or near constant concern with basic needs like food and housing, poverty evokes an image of a hamster wheel. The Bridges term for this is called tyranny of the moment, a state in which someone is so overwhelmed with crises or meeting basic needs that they have little bandwidth to plan for the future. This can be especially taxing for children. Growing up in a low-income household is associated with dietary and nutritional deficiencies, maternal malnutrition, environmental toxins, and insufficient early sensory stimulation. These differences may contribute to the achievement gap observed in academics and cognitive skills in low-income and middle-class children. Compared to children from middle-class families, low-income children are 3 times as likely to experience developmental delays. Living in poverty is associated with poor overall physical health, and low-income youths are also at higher risk of developing mental disorders affecting attention, anxiety, and mood. Another study estimated that about 36% of deaths in the US in the year 2000 were linked directly or indirectly to poverty. This national CDC-led survey asked respondents to rate their own health and revealed that respondents whose incomes were below or even up to 200% of the poverty level, represented by the blue and yellow bars, were much less likely to rate their health as excellent or very good compared to respondents whose incomes were above 200% of the poverty level. Keep in mind that this is based on the federal poverty level, which itself is arguably very conservative. In fact, when this was conducted about 10 years ago, the federal poverty level for a family of 4 was less than $24,000. Note the variation here between racial and ethnic groups, but that even so, the wealthier you are, the healthier you are within your racial or cultural group. These national findings align with research conducted much closer to home. FDR-HPO and the North Country Health Compass Partners recently concluded its latest annual community health survey and found that people with lower annual income and those with Medicaid or who are uninsured are more likely to indicate challenges in accessing various healthcare services. People with Medicaid are more likely to say they have less than good mental health and less likely to report having had a primary care visit in the last 12 months. All that having been said, you might still ask, why should I care? What can I do? It's a legitimate set of questions. If you're watching this, it likely means you occupy some position within a healthcare, likely a primary care practice, whether it's an independently owned private practice, a federally qualified health center, or a hospital-owned practice. You have 100,000 things you have to do. You may have a patient waiting for you right now, or the phone is ringing, or you need to catch up on documentation. Let's take a moment, though, to think about your team's level of satisfaction in working with patients in poverty. For simplicity's sake, let's define those in poverty by Medicaid status. What are your Medicaid patient appointment no-show rates compared with other insurance types? How well do they typically follow up with referrals and instructions? Are any of them deemed non-compliant by your practice? Are any terminated or fired from your practice for repeated non-compliance? We're asking these questions because we know, at least for some of you watching this video, because you've opened up to us about this, is that Medicaid patients tend to have higher no-show rates, higher rates of non-compliance, and are more likely to be dishonorably discharged from your practice. How well do you think all of that is working for their health? How well is that working for your practice in terms of revenue and staff satisfaction? What can be done to improve the situation? By now, this concept is probably familiar to most of you. The triple aim is a framework developed by the Institute for Healthcare Improvement, or IHI, that describes an approach to optimizing health system performance. It is IHI's belief that new designs must be developed to simultaneously pursue three dimensions, which they call the triple aim: improving the patient experience of care, including quality and satisfaction, improving the health of populations, and reducing the per capita cost of healthcare. Bridges' concepts and constructs intersect with the triple aim by offering an economic class lens to improve the patient experience for patients from diverse resource sets, design services that meet the needs of patient populations that may not identify with the stable resources of the middle class, and act as an add-on model or lens to facilitate the good work already being done toward reducing cost through lowering readmissions, increasing patient treatment compliance, and improving quality of care. We'll add that some versions of this include a fourth point, which illustrates provider and care team satisfaction. Bridges can help address this too by facilitating a healthcare environment in which care teams are better equipped to work effectively with the low-income, under-resourced populations they serve. And in fact, there are a number of healthcare practices that have been trained in and implemented Bridges-informed strategies. In this first one in Memphis, community navigators conducted outreach and case management for patients at risk of noncompliance and, by extension, unnecessary hospital readmissions, and they generated healthcare cost savings in the millions annually. A dental organization in Oregon trained its staff in Bridges and added an urgent chair so that clients could simply walk in if they had an acute dental issue instead of going to the emergency department. This is an example of truly meeting their patients where they're at. Closer to home in Schenectady, healthcare staff were trained in Bridges and deployed Bridges-informed strategies to improve their healthcare county ranking. Similar examples are found in Salem and Youngstown, Ohio, where staff were trained in Bridges with results including increased staff retention and productivity and reduced absenteeism and turnover. Going back to the Schenectady example, we can see real results were achieved in reducing uninsured rates and ED visit rates and increasing primary care engagement. These changes stemmed from a culture change that resulted from widespread Bridges training. Staff at Ellis Medicine pivoted their thinking about their patients in poverty from a largely troublesome, non-compliant population to a group of experts, problem solvers, and partners. They started asking their patients what mattered most to them, what solutions they would suggest for their own health, and incorporated workflows that truly met their low-income patients where they're at. So that was actually just the introduction. Let's move on to talk about healthcare research. First, we'll look at the research continuum of poverty as a whole. What causes poverty? Is it individual behaviors, like not wanting to get a job? Is it the community environment, like living in an area with few well-paying jobs? Is it exploitation, like if someone in poverty is trying to do the right thing and they got a job, but they need a car to drive there, but they don't have any money for a down payment and have bad credit or no credit, so they get something that comes with a ridiculously high interest rate and end up not being able to afford it, losing their car and their job in the process? Or is it the larger political and economic structures of our society, like being in an economy in which wealth becomes increasingly consolidated among the few and wage growth is stifled. This slide can be particularly helpful because it captures some politically charged thoughts about poverty, with the political right, so to speak, tending to ascribe poverty often to individual behaviors, and the left ascribing it often to political and economic structures and exploitation. This slide, again, is helpful because it acknowledges that it's actually all of these things and then some. When we turn our attention specifically to healthcare, we can look at the ingredients of healthcare, so to speak. What you see on the screen are some of those ingredients. And the text here is small, so we're actually going to go into each of these in more depth on the following slides. So we'll start with access. This considers how easy or difficult it might be to access healthcare. We can consider transportation, the presence of and type of insurance, provider and appointment availability, which could be new patient appointments or same-day appointments, whether a practice's policies exclude someone from being their patient, etc. How might these look different or be experienced differently by people in different economic classes? For instance, might a Medicaid-insured person living in the city of Watertown who doesn't own a vehicle and has mobility issues have a different experience accessing healthcare than someone with commercial insurance who has one well-maintained vehicle for each adult in the household? Next is availability, which contains some elements that may overlap with the notion of access. But here we're considering some of the healthcare infrastructure. Where are practices located? What are their hours? How many of them are there in a community? How do people know they're there at all? How many of us have heard stories from local ambulance services about people in poverty who call the ambulance, for instance, to go to the emergency department, not because they have a life-threatening issue, but because they don't have the transportation to their local clinic? There's also cost. You could argue that low-income people insured by Medicaid are fairly well positioned when it comes to healthcare costs because Medicaid typically does not include significant premiums, deductibles, or cost sharing. That is certainly true. Consider too, however, the hidden costs of accessing healthcare for these populations, which may include loss of a few hours of pay or even loss of a job if they have an hourly position, especially those in retail or food service that may not be accommodating for medical appointments. Also consider childcare and the cost of transportation. And there are plenty of low-income working households who make just a little too much to qualify for Medicaid, so they're either uninsured, are paying some type of premium for a marketplace plan, or often a significant premium and high out-of-pocket expenses for an employer-sponsored plan. Quality. To the extent that there's competition in healthcare markets, and that actual or perceived quality of care plays a role in that competition, those in poverty may not have much ability, realistically, to choose what they perceive to be a higher quality provider of care when compared to someone who has more resources. Communication. We'll discuss this in more detail later on, but for now, we'll say that all too often, the information given by health institutions to individuals in poverty is only partially understood or not understood at all. And there is a direct correlation between being poorly educated and having poor health. Efficacy is the capacity of resources to assist in health. Each of us at one time or another has filled a glass of water too full. No matter how much we wanted the glass to hold all of the water, it could not, and that is capacity. In poverty, survival tends to be a daily challenge. A number of issues or crises occur at once. Resources are scarce, and the compounded impact lessens the resources available. The research areas we just discussed, access, availability, cost, quality, communication, and efficacy, shine light on some of the population health disparities that exist for people in poverty. We can also think of these as social determinants of health, a term that many of you are familiar with and that increasingly factors into value-based care. Research indicates that poverty alone places people at higher risk for heart disease, even after controlling for other risk factors like smoking and high blood pressure. If we were in a room together, we'd want to gauge your reaction to this statement. Do you find this surprising or not? Believable or not? If this is true, as this study has indicated, then what hypotheses would you have for why this is? How do we measure or gauge the presence or absence of pop health disparities? The list on the screen is a good start. The authors of Bridges argue that awareness and the ability to notice these attributes are as critical as noting physical symptoms in a patient. We would also note that several of these, including education, employment, food security, healthcare access, housing, income, and social support systems, among others not captured here, such as transportation, are addressed in the social determinant of health screening tool utilized by NCI partners in the Medicaid Transitional Care Management, or MTCM, pilot program. There's another aspect that isn't quite captured in these research areas, however, and that is about interpersonal interactions and relationships. If we think about the mental model of poverty, which we will discuss in a few moments, at its center, you'll see the word relationships. Think about how your care team interacts with patients overall and specifically those in poverty. These quotes were taken from an interview with a healthcare provider in the US who indicated that in the NICU, if staff perceived the mother to be middle class or wealthy, there was an assumption that something happened out of her control to warrant having her baby in the NICU. But this assumption was not extended to mothers who appeared to be in poverty. Is this healthcare provider accurate in her perceptions about the different ways some staff members react to the economic class of patients? Might there be a connection between the way one perceives a patient and the care that patient is given or not given? Let's wrap this module up by taking a moment to reflect. Can you identify healthcare outcomes that may be influenced by access, availability, cost, quality, efficacy, or communication? After you think on that, identify one change that you can implement in your practice more or less immediately. Finally, what can you and your team do to build even better relationships with those you serve who are in poverty? Please incorporate your ideas at this stage within the handout about implementing Bridges concepts that we sent along with your book. Let's get a little deeper into the Bridges lens. As we mentioned before, Bridges is not a program per se, but more of a strategy, a lens. If you serve patients from different economic classes, Bridges can be useful to your practice. It aligns perfectly with the patient-centered medical home model because it can help you better understand and work with those of your patients who may be under-resourced or struggle with social determinants of health. Notice several of these bullets talk about having voices at the table, having a discussion. What this references is a key Bridges tagline, which is "Nothing about me without me," meaning if a practice or any institution is going to discuss or try to implement solutions for or about a certain population, it's imperative that you involve members of that population at the literal or figurative decision-making table. In this case, these bullets come from a staff member at Ellis Medical System. One way they incorporated Bridges into their system was by meaningfully engaging low-income, under-resourced people in patient advocacy groups that helped influence decisions within the medical system. This perspective is consistent with the notion of whole patient care. Too often, yet understandably so, in the medical field, we may deconstruct individuals according to their vital signs, their illnesses, chief complaints, or the workings of specific systems within their bodies. Bridges' emphasis on relationships with people in poverty encourages a nudge toward a more holistic relationship with that patient. Any face-to-face time you have with them is precious and can be maximized. We've heard this from some providers in our region who emphasize, for instance, the utility of a Medicaid transitional care management service. If one of their Medicaid patients is discharged from the hospital or ED, that's an opportunity to meet with that patient, discuss what brought them to the hospital or ED, and how they can work together to avoid a similar future situation, all while building a relationship with the patient, asking them what matters to them, and working to close any open care gaps that exist for the patient. We've used the term under-resourced a few times so far because it aligns with the Bridges definition of poverty, which is the extent to which an individual does without resources. What do we mean by resources? So Bridges categorizes 9 resources. And it's important to note that while financial resources is one of them, there's also emotional, mental, spiritual, physical, support systems, relationships and role models, knowledge of hidden rules, and knowledge of the formal register. And those last 2 we'll get into in a few moments. You may have worked with patients who were incredibly impoverished financially, but maybe they had resilience in other resource categories. Maybe they had an extensive, somewhat better resourced, healthy family structure, for instance, or an unshakable spiritual connection that really kept them going. You may also have worked with patients whose income might not have fallen within poverty guidelines, but they were experiencing extreme chaos in other areas of their life. In this sense, they too are under-resourced. We're going to talk more concretely about hidden rules in a bit, but for now, it's enough to say that as human beings, we live in environments, and these environments tend to be shaped by things such as socioeconomic class, as well as religion, race, language, and region. Environments tend to develop their own sets of norms, which Bridges refers to as hidden rules. When you're living in that environment, the hidden rules are simply known to you. Like the classic example of a fish in water, you might not be able to describe the rules because they're indistinguishable from your environment. But hidden rules become very visible when the environment changes or when you encounter someone with a different set of hidden rules. For instance, as a civilian, I become somewhat nervous and on edge when I go to Fort Drum because it's a totally different set of rules that feels to apply there. I'm not familiar with the names or the institutions or the military ranks, and it's best if I go with someone who is familiar with those things and can help translate for me. With that being said, as people who work within a healthcare practice, we can ask ourselves, does our practice have its own set of hidden rules? Who knows them and who doesn't know them? When any of our patients walk through our doors or otherwise interact with us, do they feel like I do when I go to Fort Drum? Another example of this might be to imagine showing up to play in a soccer game, but everyone else is playing lacrosse. You don't have the right gear, you don't know the rules, you're not speaking the same lingo as everyone else. Might you feel confused, frustrated, powerless, tapped? And importantly, how well are you going to play? Before we go further, some key points to highlight and some disclaimers. We talk about the economic classes of poverty, the middle class, and the wealthy. But let's acknowledge that rather than being three perfectly distinct and static groups, these are simply useful buckets or patterns. And of course, patterns have exceptions. It's also worth spending a moment on another pattern, which is the distinction between generational and situational poverty, because you may have patients in both of those categories. Generational poverty refers to multiple generations of family lineage that have lived in poverty for most, if not all, of their lives. These individuals may be deeply rooted in poverty, may be very uncomfortable or unaware of the hidden rules of any other economic class. They may not have many people in their social support system that are from a different economic class. Whereas people in situational poverty may not have been raised in poverty, or their parents or grandparents may not have lived in poverty. But situational factors like the loss of a job, a cancer diagnosis, a house fire, etc., have placed them in poverty for now. Depending on the strength of their overall resources, they may or may not get out of poverty within their lifetime. Point number 8 here references the fact that most systems and institutions use the hidden rules of the middle class. Again, if any of your patients aren't familiar with these rules, might that impact their ability to meaningfully interact with your practice? We can use these 10 bridges constructs to test a program or initiative to see if it truly meets the intentions of the bridges lens. Be open to the experiences and environments of people who aren't like you. When you build relationships of mutual respect with your patients, do you find those relationships to be particularly fruitful in terms of the patient's health outcomes and possibly your own professional satisfaction? If some of your patient panel is under-resourced, involving them through meaningful surveys, informal conversations, formal discussion through a patient advocacy or advisory council, or other methods can be a true win-win. You win because your practice gains information and perspective from your customer base, which you can use to build brand loyalty, and doing so can also more meaningfully engage the patients you involve. And your patients win by finding a voice, feeling respected, and heard. How can your practice help build your patients' physical, emotional, mental, and support systems resources? So in closing of this module, we would just note that, as we've shown a bit before, health systems that have benefited from incorporating the Bridges perspective have trained staff at all levels in Bridges. And this obviously is really part of what we're trying to achieve through this video and training opportunity. In this section, we'll take a closer look at 3 signature Bridges elements: mental models of economic class, resources, and hidden rules. What you see here is an example of what is called a mental model, which is a picture in your mind that describes a certain phenomenon or category of something. It can often convey the gist of something in an easily digestible way. Bridges examines mental models of economic class, and this is a mental model of poverty. If this were a full-day training, we'd actually build something like this on our own. We'd ask you in small groups to imagine a person living in poverty in your community and to list the elements that are part of their day. What places do they go to? What types of things are they concerned about that day? You'd put these in the main circle. Of the items you see in the circle, such as food, childcare, agency time, by which we mean time spent at places like maybe DSS, HUD, food pantry, etc., and legal issues, which would you likely have included? Are there any in the circle that surprise you? Is there anything you would have included but you don't see here? The smaller circles on top represent the type of community institutions people in poverty may interact with regularly. And on the bottom, you see examples of businesses. So if you think of a pocket of poverty in your community, you will often see certain organizations, services, and businesses. Are these present in your community? When I think of an area of higher poverty in the community in which I work, Watertown, I sometimes think of State Street. And as you drive down State Street, you definitely do see many of the types of businesses that you see on this slide. This obviously will look different in more rural parts of our region where businesses themselves are just few and far between. What the authors of Bridges concluded from drawing multiple mental models of poverty with people who were experiencing poverty was that the sort of glue that was holding this model all together, the central theme running through it, was relationships. People in poverty often rely on people near them, their families, their friends, their neighbors, to get things done, to get by, to survive. When we take a step back and analyze this further, what do we see? This mental model in its analysis was first created by a group of people in poverty in central Ohio. This model is going to be somewhat different by region, race, ethnicity, and cultural history. But there are common features that often appear across models throughout the U.S. The red jagged shapes you see in the circle represent crises, fires that have to be put out all the time, like having car troubles that you can't easily fix, which leads you to be late again to your retail job, which might lead to losing your job, which might lead to you not being able to pay rent, which might lead to an eviction notice, and so on and so forth. Experiencing these constant fires is stressful, lonely, frustrating, and further erodes your ability to plan ahead. They also often feed off one another and create one another. Someone in this situation might feel like a hamster in a wheel, running hard but not getting anywhere. To the left, you see some other observations of what life in poverty can be like. Feeling the tyranny of the moment, or having the feeling of having so much to worry about basic needs for today that it's impossible to think ahead or plan for the future. A feeling of hopelessness, that everything that's happening is out of your control. You also see the term AAA here, and this refers to a transportation example. So transportation almost always shows up in a mental model of poverty because when you're in poverty, you often can't afford a reliable car, or for those in more urban areas, affording public transportation may also be difficult. Many people in middle class are AAA members, or they have some other roadside assistance program. So if your car dies, what do? You're probably upset. It's not fun, but you ultimately are able to pull over and you call AAA or some other program that you're part of, and they come within a reasonable time and they take care of the situation for you and you move on with your day. But in poverty, you really often don't have the luxury of doing that. You don't call someone like AAA, you call Uncle Ray. And Uncle Ray might come out with a truck and a chain, and he'll haul your car back home. People like Uncle Ray are the reason that relationships is written across this chart. One woman in a Getting Ahead group told the facilitator to draw several lines around the perimeter of the circle with a big, thick marker because once you're in there, it's really tough to get out of it. To give you a more local example, this is a mental model of poverty created by Getting Ahead investigators in a workshop held at the Watertown Urban Mission. Getting Ahead is a 16-week workshop series where people living in poverty come together and investigate poverty in their own lives and communities. They are given the space to get out of the tyranny of the moment, even for a few hours a week, and envision a future for themselves, and they make plans to achieve that future. Take a moment to digest this. What feelings do their word choices evoke? These mental models were created by adults, but consider the children that grow up in poverty and the cumulative weight of the stress they may experience. This study found a correlation between ACEs, or adverse childhood experiences, and developing autoimmune diseases as adults. This slide continues the investigation into a middle class environment. How does this mental model of the middle class compare and contrast with that of poverty? Instead of jobs, we see careers. Food and clothing are replaced instead with the word shopping, which implies sort of a routine and choice. And we see future-oriented elements like planning for vacations, preventive health, and retirement. There are some of the same elements as within poverty, like family and friends, childcare, and mental health and chemical dependency, which plagues all economic classes. The community institutions on the top are the same, but perhaps they interact with them differently. The businesses at the bottom are also a bit different. The mental model of wealth is next level. We won't spend much time on it, really, except as a foil for the other two models. So if you step back and compare the three, one observation you might have is that the environment of poverty is very unstable. So people have to focus on solving immediate, concrete problems. The environment of the middle class is more stable because people generally have today's needs covered, and they can worry about the future and focus more on planning. The environment of wealth, by contrast, is so stable that people don't worry about today or tomorrow. They can make decisions based on family traditions. Let's also talk about this notion of time horizon. So in other words, how far into the future might people from different economic classes look into? The time horizon for people in poverty is arguably the present day. The time horizon in middle class might be more like 4 to 10 years. So you hear people having 5-year plans. People can make plans about their careers or building a family or buying a home, for instance, years in advance, and they can reasonably expect to see them through. The time horizon in wealth, however, is generations. So if people's daily lives in different economic classes look differently, if they have fairly distinct environments, do those environments come with a set of their own, often hidden rules? What happens if someone who is fluent in the hidden rules of poverty find themselves in a middle-class environment or institution? Will they be prepared to succeed? For example, how might the 3 economic classes look at food, for instance? So this is an easy example because it's relatable to everyone. In poverty, quantity tends to be the most important. So that sort of is its own a hidden rule. An example of a restaurant, that comes to mind when you think about quantity would be an all-you-can-eat buffet, sort of a Ponderosa. Versus in the middle class, quality tends to be the most important. So are the ingredients organic? Are they locally sourced? Are they clean? You might envision someplace like Core Life, for instance. Versus for the wealthy, presentation of the food is arguably the most important. In truly fine dining, you'll be served multiple courses. There might not be much served on each plate, but the elements are very artfully presented. Another very different example is the hidden rules of destiny. In other words, to what extent are we controlled, and what do we control? Among the truly wealthy, there is this notion of noblesse oblige, which means that those who are wealthy are called or obligated to act generously, kindly, and righteously to those in society who are less privileged. An example might be the Gates Foundation. In middle class, you might not be able to establish large foundations with the power to change entire communities, but it is generally accepted that you can do things today that can help provide for yourself and your family in the future, like invest in retirement accounts. In poverty, there can be a sort of shrug of the shoulders that indicates that there's not much that I have control over. If something's going to happen to me, it's simply going to happen. For healthcare, this has huge implications. If you're speaking with a pre-diabetic patient about lifestyle changes they can do or medications they can take to prevent a future diabetes diagnosis, and the patient isn't connecting with you or isn't receptive to what you're saying, it could have to do with poverty's hidden rule of destiny. It's quite possible their siblings, parents, grandparents all had diabetes. They may take it for granted that they'll have diabetes too, no matter what they do. Another classic example of this is with dental health, and it's something that was imparted to me as someone who grew up in poverty. As a teen, I had a job at a local restaurant and had saved enough money to start going to the dentist. I wanted to have braces someday. But my dad waved his hand dismissively and said, "Don't even bother. All my parents' teeth fell out, and mine did too, and so will yours. There's just not much you can do about it." When you're working with someone who comes from that type of background, it can be hard, but not impossible, to meet them where they're at while still working toward a positive health outcome. So how can we use the knowledge of the hidden rules to our and the patient's advantage in healthcare? We can appreciate the fact that good health requires resources. It takes a level of stability. It takes a level of planning. The very notion of preventive healthcare does not resonate well with people in poverty because they are much more concerned with fixing the breaks, paying the water bill, avoiding eviction. Preventive healthcare might not be at all relevant to their environment. So if you're fortunate enough to get them in for a preventive appointment, or any appointment at all, can you take advantage of that opportunity to build on your relationship with them? One simple strategy is to ask patients what matter to them. Some or all of you may recall the What Matters to You framework that we discussed as a region during DISRIP. This aligns very well with what we're discussing in this training. So does motivational interviewing. If you know what matters to a patient, you can leverage that to work together to achieve good health outcomes. Now that we're talking about the nuances of patient-provider relationships, let's talk about communication. Communication can be a barrier or a bridge, depending on how it's used. There are two general discourse patterns or ways of speaking. The formal story structure is expected at school, at work, and in other settings and organizations. It has a beginning, a middle, and end. It gets to the point. A casual story structure, on the other hand, may start at the end, then weave in elements from the beginning and the middle, peppered with lots of nonverbal communication or interjections from friends and family. The top box here illustrates the formal story structure, which has a clear-cut beginning, hence the B. It moves through a sequence of events, a plot, then down to a definitive ending, E. This story tends to move chronologically, past, present, and future. It's about sharing information. The casual story structure, on the other hand, has no clear-cut beginning. The story may start with the present moment, or 3 months ago, or with an entirely different story. One person might start the story, often at the most dramatic moment, with openness to comments from listeners, which isn't seen as interrupting. The triangles represent where others may jump in with jokes or remarks, especially if there's a relationship between the storyteller and the listeners. Then over-talking is fine. If you go to page 64 of your book, you'll see Carl's story, which illustrates a casual story structure in a healthcare setting. So what might this look like in healthcare? Do you ever ask patients why they were late or didn't show to their appointment or why they didn't pick up their meds? Is the answer you get sometimes casual or circular? In the medical community, we almost always communicate in formal register, whereas our patients in poverty may speak in a more casual register. This can lead to a communication breakdown between parties. Brain research indicates that the best time to develop learning is from birth to age 3. Children in poverty typically enter kindergarten 2 years behind their peers. How do children make up 20 million words when they get to kindergarten? Affirmations encourage children to speak. They might be questions like, what are you looking at? What does the bird look like? What is the bird doing? This is the amount and type of talk initiated by parents in a middle-class home when a 3-year-old climbs on the couch to look out the window. In poverty, the situation might be handled in just 2 words, get down. This study found that in middle-class homes, there were 5 questions of, what are you looking at? Or affirmations, to every one, get down, or prohibition. Parents in poverty love their children, but the tyranny of the moment influences the amount and the kind of talk in their home, especially if there's generational poverty. What programs in our community work with parents to increase language experience in the birth to age 3 time period? There are multiple, and as healthcare providers, we can support our patients through referrals to these types of programs. Another study found that children who grew up in poverty also experienced things like overcrowding, noise, parental separation, exposure to violence, and other stressors. And that children in extreme poverty ended up with up to 6% less brain surface area than children from higher income families. And finally, that childhood stress is linked with depression, heart disease, and addiction in adulthood. As primary care providers, you may treat patients across the life cycle. For children and their parents, referrals to early childhood intervention programs or social care programs can be life-changing. For adult patients, you might find those referrals helpful, as well as this on the screen may be a helpful communication tool. The scale at the top represents a lifetime of 90+ years as a way to establish the patient's age and emphasize their future. The stability scale at the lower left establishes the instability factor in the patient's life. See Stability Scale Indicators in Appendix F of your book. The past, present, and future sections provide space to examine the present situation in detail and create a concrete plan for disease management for the immediate future. The information about the past also may have a bearing on the decisions to be made. The spaces below the line for the past and present are to note significant information. The space below the future is for the concrete plan and the steps that the partners will create, partners being the professional, caregiver, and the patient. And the circles beneath the support team provide a place to brainstorm which family members, friends, and/or professionals in their lives can support the patient in achieving their wellness goals. We'll show you on the next slide an example of how this mental model might be used. This sketch is for a congestive heart failure patient who has had 2 heart attacks and is experiencing diminishing heart strength. The patient is now 63, and has had numerous hospital stays. Her body is filling with fluid. She has edema due to the disease. The sketch is a mental model that is especially effective if a patient does not have a strong sense of their future story. Poverty environments tend not to grow power, future orientation, reliance on choice, or planning. So using a mental model like this can be very powerful. It cuts through all the medicalese and creates a hands-on, simple, meaningful planning tool that makes choice and future story very clear and concrete. On the top is the patient's past, their present, noted by the asterisk at age 63, and the future story on a timeline. Below that is the patient's health outcomes. Time is an abstract concept, and this timeline is a tool we can use to make time more concrete. You could tell the patient simply that heart failure is causing edema and that her heart function and ability to breathe will diminish in the future if she doesn't follow the treatment plan, and she could die sooner. Or you could sketch this and say something like, look how important it is to watch how much salt you eat and drink, keep to your diet, and keep your weight down, and take that pill every day. That's the green line. Things could go well from here if you do those things. Compare that to not doing them, which is the blue line. If you ask the patient what matters to her and she talks about her family, that her grandchildren are in school, that she wants to see them play sports someday, you might be able to talk about how that may be difficult if she can't breathe well enough to walk. But there are things she can do so that she can go to their games and cheer on from the sidelines. The slide lets the patient see into the future story and links the treatment plan to the relationships that they have in their lives. It's also low tech and very simple, requiring only a piece of paper and a pen. So some concrete steps healthcare providers can take to communicate with patients in poverty are listed on this slide. The first one might require additional resources and/or a change in workflow. There are some agencies in our region, including the Northern Regional Center for Independent Living, or NERCL, and the Mental Health Association, among others, that employ peer advocates who are able to attend their clients' medical appointments. If you still have COVID-related limitations on visitors, you can consider how to incorporate these advocates via phone or video chat. These next four are fairly straightforward, and you can use the diagram on the previous slide to help you communicate. You can ask the patient to teach back what you just discussed, because doing so can reveal how much of it they truly understood. And you can ask patients what matters to them. Doing so can give you critical insight into what will motivate them. We're going to now turn our attention to healthcare providers as institutions. So when people in poverty around the country are asked if there are any difficulties in accessing healthcare or any bad experiences they might have with a practice, here are some common answers. The practice may not be open in the evening or on the weekends when they need them. They may struggle with arduous, repetitive paperwork. They may not feel respected by staff or feel like their primary and specialty care are disconnected. They may wait too long in the waiting room or receive bills they can't decipher. On the flip side, if you ask healthcare providers from around the country to describe any challenges they face with serving people in poverty, they may come up with these answers, such as high late or no-show rates as compared to commercially insured or middle-class patients, being frequent flyers or super utilizers of the emergency department, and being non-compliant with treatment plans or recommendations. Do any of these resonate with you in your practice? If so, what can be done to improve the situation for your and your patient's sake? Simply expecting your patients to start being on time and compliant is not likely to work. And instituting punitive consequences, such as discharging patients from your practice after a specified number of late arrivals or no-shows, or charging patients for missed appointments, is not likely to institute meaningful change and will result in more people in our community who do not have primary care. We visited this example earlier in the training, but it illustrates how a health system in Schenectady embraced Bridges' inspired changes and saw fruitful results, including an improvement in their county's health ranking, a decrease in uninsured patients, and a significant increase in their primary care volume and revenue. So when a healthcare institution is at its best, here's what it might look like. Which of these apply to your practice? Are there any areas that could be improved? As you watch this video, think about any aspects of your practice that are ripe for improvement. Having opportunities to improve is not a bad thing. In fact, it's a mark of a highly functioning institution when it regularly evaluates itself. In the interest of action, this slide asks you to pick 2 areas within your practice that are most obvious or urgent. Considering the tools and strategies we've discussed so far, along with your own innovative ideas, what are some ways to improve those areas? This brings us to our final module in this training. How can we maximize our care team's interaction with under-resourced patients? How can we link these patients to positive personal and professional supports in the community that will help them achieve their and your health goals? As we navigate communicating with and serving patients, it can be helpful to frequently reference this slide because it succinctly captures some of the typical differences between under-resourced and more stably resourced patients. People in under-resourced or poverty environments are often just trying to survive. They approach healthcare from the tyranny of the moment, which is to say, perhaps not at all, or perhaps a little too late. They may embrace an informal or circular communication style, perhaps to the frustration of your care team. They may rely on the people closest to them to help navigate the healthcare and social care systems, and they may have a hard time admitting they need help. In stably resourced or middle-class environments, we tend to see people who aren't fighting to survive, but are instead moving toward a thriving state. They may be looking longer into the future of their own and/or their family's health. It's important to be seen as capable and self-sufficient. They may speak more directly and to the point and expect similar from their care providers. And they may rely on their own health-related knowledge and contacts within the medical field. Assuming you work with patients from both of these environments, you might consider how your practice formally or informally screens patients for their level of resources, and how you can use this awareness to even better meet patients where they're at. This is related to the 5th bullet on this screen. Knowing how strong your patient's resources are can greatly help you partner with them to achieve their health and wellness goals. You might use insurance status as an initial indicator of resources, for instance, whether the patient has Medicaid versus commercial insurance. But following that up with a standardized social determinant of health screen can help uncover areas of strong or weak resources and help you identify needed community referrals for the patient. A few more things before we close. We've mentioned social capital or social supports throughout the training. Here's a diagram of a hypothetical patient support system. In Bridges, there is the notion of bonding versus bridging capital. Bonding capital is people with whom you have a shared culture or experience, and they often help you get by. They can be family members, friends, neighbors, etc. And then there is bridging capital, and these are people who can help you truly get ahead. These can also include family or friends. They can also include resources in the community and can be people from a different economic class than you. So for instance, if you're working with a patient who's been a long time heavy smoker and they're coming around to the idea of quitting, it can be very helpful to plot out their social supports. If they live with smokers, it may make it especially hard to quit. But if they do have a close friend or a family member who also wants to quit alongside them or otherwise support them, they can be a huge ally. How can your practice team serve as bridging capital by being a positive and encouraging force in the patient's healthcare journey? And what other bridging capital supports exist in the community to which your practice can refer patients? In the last slide, we just mentioned the terms getting by versus getting ahead. One of the key principles of the Bridges lenses is to engage people in poverty at the decision-making table. There are many right ways to do this, including conducting quantitative patient surveys, more in-depth interviews or focus groups, or recruiting patients from all economic classes to serve on a patient advisory council for your practice. You can also meaningfully refer under-resourced patients to Getting Ahead workshops in our community. These workshops bring together usually 6 to 12 under-resourced people for a 16-week workshop series. They each get one of the purple books that you see on the slide. They are given a gift card after each session. There's usually a meal served at each session, and the series is led typically by 2 trained facilitators who guide the group through the material. Getting Ahead participants are referred to as investigators because they investigate poverty within their own lives and their communities. They provide valuable research into what poverty looks like within a community. And the workshops afford them the time and mental space to envision a future for themselves and make plans to achieve that future. Our region has a thriving Getting Ahead presence. Pictured here are 10 Getting Ahead graduates. 2 of them acted as facilitators for this cohort, but had previously graduated from an earlier cohort. And the other 8 celebrated their graduation from the 15th Getting Ahead cohort in Jefferson County on February 27, 2021. They are survivors of substance abuse, domestic violence, depression, and a host of other struggles. They are survivors of generational poverty, and they are on their way to a new future story. There are multiple Getting Ahead cohorts happening in our region, currently mostly centered within Jefferson and Lewis counties at this point, although we would like to see some happen in St. Lawrence County as well. We even have our region's first Spanish-speaking Getting Ahead group happening right now. If you have patients that you think might be interested or a good fit for this Getting Ahead experience, reach out to us at FDRHPO. We co-facilitate our region's Bridges Out of Poverty Steering Committee, and we can help let you know which sessions are recruiting. And we'll note too that the well over 100 Getting Ahead graduates in our community are tracked up with regularly. There are people who talk to them, who try to engage them in what's called staying ahead so that they have support long after they graduate. And we've seen some really impressive outcomes from these graduates, from maybe getting a job or getting a better, more stable job, to things like reuniting with their children, buying a home, getting their driver's license, getting their GED, getting involved in civic organizations and boards of directors in our community as well. So here are some potential action steps we would really love, for our practices to consider. Each one of these is useful. I'll let you take a moment to review them. And as we've mentioned before, what matters to you and motivational interviewing also align very well with the Bridges concepts and can help enhance your work with under-resourced patients. Contact us at FDRHPO if you'd like any information on these 2 strategies. So at this point, we'll ask you to get out your handout again that we sent along with your books. And this simple sheet can help you translate this training into something actionable and concrete. Please reflect on this training and complete the handout. Most importantly, pick a couple things your practice can do now to enhance your work with under-resourced patients. Like dozens of other healthcare institutions nationwide, doing so can further improve the health outcomes of your patients while also increasing staff satisfaction and often revenue, often by maximizing your patient appointment slots. So what is next? You will receive a brief training evaluation. Please complete it so we know what about this training worked well and what could use improvement. Next, your practice has likely identified one or more staff to attend a roundtable hosted by FDR-HPO and NCI on October 18th, 2022 at 11:15 a.m. at the Hilton Garden Inn in Watertown. You'll receive a brief survey. Please complete this before attending the roundtable because it will help us tailor the event to your needs. We'll serve lunch, debrief on this training, discuss identified solutions and best practices, and we'll share results of the focus groups that we've conducted with under-resourced individuals throughout Jefferson, Lewis, and St. Lawrence counties. We ask them about their access to and experiences with primary care in the region. Finally, we'll brainstorm strategies and solutions. All of this synergizes with your work in value-based contracting, PCMH, and will be critical in the event New York State's 1115 waiver is put into motion next year. With that, on behalf of FDR-HPO and NCI, we thank you so much for engaging in this training, and we look forward to seeing you on October 18th.